Good afternoon. It's nice to have this update with staff out in the field. We met with the central office staff and the area administrators, although the administrators were remote video conferencing in this morning. And I wanted to share with you a couple of the highlights of what's going on that I shared with them earlier today. First of all, I know a lot of you were in parts of the state that had some of the adverse weather yesterday, so I hope everybody fared well. I know some of our counties closed early, and I always support that because it's a safety issue in terms of our workforce. So I hope that everybody stayed safe and dry and warm yesterday. I wanted to start off by talking about the budget. The legislature is in session, and that is consuming an incredible amount of time on the part of myself and even more on the part of Michelle Jones and Ricky Elliott. Ricky has sort of moved into that role and assuming more duties with the legislative activities, and they are in full steam ahead. I guess they've gotten about somewhere around 14 days under their belt. Is that right, Michelle? About day 8. Okay, so finished with 1 week and in the middle of the second week. And we have worked the halls and worked the legislators on a number of different bills, some of which we are sponsoring and interested in, and others that sister agencies are putting forth. And I'll explain a little bit more about that in just a bit. But I just wanted you to know that in all of that to do with the legislature is obviously the budgeting process. And I'll remind you that our request for fiscal year 18 is that we get back to where we were in fiscal year 16. Between 16 and 17, we took a cut of about $4.5 million, $4.6 million, and our request to the pre-session joint committee, the House and Senate budgetary representatives and senators, was that we get made whole essentially and have that $4.6 million restored. It remains to be seen. They actually have not undertaken much of the budget discussion, at least not publicly at this point in time. So we remain hopeful in that regard, but I think you know as well as we do, the big demands on the budget are Medicaid and the correction system, with both of those needing ever more dollars to sustain them current operations and proposed additional expenditures. With the prisons in particular, the initiative to hopefully float a bond issue in some degree to build some new facilities to replace their current very stressed and utilized facilities across the state. And of course that gets into the politics, as does everything, with a lot of competing interest over limited dollars. So we'll wait to see how we fare in terms of the legislative appropriation, and certainly we're doing the best we can to tell our story and to share with legislators and policymakers how important the work of public health is. I do know that there's been some discussion about a cost of living increase of some sort, whether it's a traditional COLA or one-time funding in terms of bonus-type money for folks who have been salary stuck for an extended period of time. Whatever shape or form it takes, we'll certainly be advocating where possible to make sure that policymakers are aware of how hard state employees, and in particular the folks in the health department, work on a day-to-day basis, because that is frankly long overdue. I think the last COLA was in 2008, and we've had maybe one very limited one-time bonus, if you will, a couple of years ago. But we'll certainly advocate for that, because it's just hard to keep up when you've got inflation and you've got an increase in your health insurance. I'm sorry, not only health insurance, but your retirement share. It's very difficult to watch you know, the dollars get stretched further and further, and that is something that I think is very important, and I'll continue to advocate for. when you look at some of the work we're doing, and I hope most of you are familiar with this, our efforts to realign the geography for the districts, we're going to be calling them districts, the public health areas, which currently are 9, not counting Jefferson and Mobile. We have 9 that will go to 6, effective the 1st of October. It seemed like when we started to lay the groundwork in the planning and slicing and dicing and trying to decide exactly how the appropriate configuration should end up being, that seems like it's been, just yesterday that we were doing that, and we charted a course to make it effective 1 October of 2017, and now we're just a little bit over 6 months away from that. So, again, time just evaporates, and I think that the work that's gone into that has really been a yeoman's job on the part of a lot of staff, both from the areas and the central office. So I applaud those individuals. As it gets closer, we will work through a lot of the issues that we have been putting a lot of thought into in operationalizing them. Some of you have seen that here and there across the state as we've taken advantage of some opportunities with vacancies and sharing staff across current area lines, and we'll continue to look at those opportunities. Hand in hand with that, we have the work to look at the appropriate staffing and production model. And obviously, this is primarily in our clinic operations. We have seen over time a decrease in the units of service in various programs, in particular in family planning, immunizations, those programs that we've done throughout the years. But we've not seen a parallel adjustment, if you will, in the staffing that is out in the counties. Here and there may be some few exceptions to that, but in general, we've not seen a similar sort of reduction in staff to reflect the business demands for the services that we provide. And as we've looked at taking a more business-like approach to that, a lot of work's gone into defining the units of service across those various clinical programs and assigning the staffing model that would be appropriate for those. And we are looking at implementing that over the coming months. And I want to assure you that when you look at what's the appropriate staffing, the notion of, or the question about reductions in force always comes up. And I've said before, and I'll continue to say that that is one of the last things that I will do without any compelling reason. We're going to take advantage of attrition, retirements, and resignations, and things of that nature, and certainly keep any potential for a reduction in force as the very last resort, and that would take place only if budgetary challenges left us with no choice. We are looking at 1 October, as I said, for the new districts. We're looking over the coming months to sort of map out a more firm implementation date, if you will, with the staffing and production piece. But when you back up from both of those pieces, and they do kind of go hand in hand in a lot of ways, I want to restate the reason that we're doing this is not just to disrupt lives and to throw things out in a time that's already tumultuous with a lot of unknowns, but it's to position the agency in the best way possible to weather any potential financial storms. We did that during a time when the Medicaid agency with the regional care organization model was underway, and it's still continuing, but that's been a very, in and of itself, a very tumultuous course on the part of, I think the Medicaid agency would tell you that, with just this week, the announcement that one of the key players that was part of the RCO in each of the 5 regions thrown in the towel, so to speak, and that has been one of the major changes that we've seen, again, just this week. Earlier, there had been a couple other probationary RCOs, entities that had withdrawn And now with this new one withdrawing this week, it makes it even more, I think, challenging for the Medicaid agency as they move forward, and certainly whatever implications may come from the federal level, because the whole RCO model is premised on the waiver that was granted from CMS. All of that's a story that waits to unfold, so we'll stay tuned to that, but that's part of the mix in terms of looking at the potential for financial challenges that put us on this course of being more streamlined, if you will, where possible and where appropriate, again with the new 6 districts and the staffing and production model. On that note, with the new administration in Washington, the Trump administration, there's a lot of unknown around CHIP, the All Kids program. Currently, for both fiscal year 17 and 16, the federal government is picking up the entire state match. They're paying 100% of the program essentially. Prior to 16, the state had a share, a match to pay, and we don't know what's going to happen for fiscal year 18. And that's just part of that long list of unknowns that we continue to monitor and keep our eye on the mission of public health and the service that we provide through those various programs. There's conversation around some of our federal grants, the Preventive Block Grant in particular, which goes to the states, and just about every grant, I think, is being looked at, including those that flow through the Centers for Disease Control. So a lot of unknown, federal level, state level, state being both Medicaid and the legislature, and stay tuned, and we will figure it out as we go along, because that's what we always do. I want to share one piece of legislation with you that we're really working hard on, and I think it tells a story about what public health really is all about. It's easy to get lost in all of the busyness and the fretting and the what if and the playing out different scenarios, but I want to share with you something that I've become even more committed to over the past few months, and that is a infectious disease control reduction act that we haven't had it introduced yet, but we are carrying this bill as an agency bill. And what I would like to do is give you a little bit of background. You're aware, I think, because it's certainly in the headlines, and some of you are seeing it locally, and some of you have had friends or family, and this has touched your lives personally. But I'm talking about the prescription opioid and the heroin epidemic, the overdose epidemic, and certainly tragically the number of overdose deaths that we're seeing as a part of that. This is playing out on both the national stage and in each state in the country, and Alabama is no exception. And what happened in 2015 and 2016 was an outbreak in a very small town in Indiana, Austin, Indiana. I think the population's about 4,000, and they had a lot of heroin drug use, and folks were using dirty needles. And they had an outbreak of HIV and hepatitis C associated with multiple folks using dirty needles and the blood transmission of those two diseases. And at last count, there were 190 cases of HIV. They are estimating that the lifetime cost of taking care of these individuals from a medical standpoint is somewhere around $70 million. That's the latest figure that I saw. And many of those folks will be on Indiana's Medicaid program. And so when you look at the health care cost, aside from the impact on people's lives, what it signifies, I think, is that there's this other piece of the heroin opioid epidemic that's not just the overdose deaths, but it's in the realm of communicable disease and some pretty serious diseases, obviously, when you talk about HIV and hepatitis C. They're chronic, they're not curable. There may be some exception with hepatitis C with some of the more recent drugs that have been made available, but what we are looking at is a study that CDC published relative to that outbreak in Indiana, and they took the risk factors that led that community to experience that outbreak and assessed counties nationwide. And they came up with 220 counties, that they are deeming as vulnerable and at risk, on the edge, if you will, from my term, for such an outbreak in each of those counties. And Alabama is on that list with 4 of our counties. They're in northwest part of the state. And what this bill that we're promoting is to have a program that would bring 2 or 3 things to a community. We would do this on a pilot basis. A health officer would deem a county an appropriate risk-based site for one of these pilots, stand it up with a community-based organization, and it would actually primarily have a syringe exchange program. That means for those folks who are struggling with addiction and are using needles, they could bring their dirty needles in and exchange them for clean needles. We also would provide the naloxone, the rescue drug for overdose deaths, and most importantly, we would counsel, educate, and make referrals where possible to get these folks into the treatment that is so desperately needed, and at the end of the day is the ultimate goal, to get folks the help that they need to beat the addiction. The reason we need legislation is around the syringe exchange, and that's because the drug paraphernalia law that's currently on Alabama's, it's an Alabama statute, would make it illegal for those folks if they got caught with the syringes. It would be something that they got arrested for. So this program would give them, if they were appropriately enrolled, a card so that they could produce that if they were encountered with law enforcement, and it would be something that said they had coverage, if you will, to have those syringes that were provided through this program. I think that's a very important bill for us to promote as public health practitioners. Is a very important part of our toolbox in terms of doing prevention. If this sort of initiative in a community could prevent an outbreak similar to what was seen in Indiana, I think that that would be the right thing to do. There are a lot of political considerations. We are working with key legislators, especially the handful of legislators that have those 4 counties that made this CDC list, and other leaders in the Senate and the House, and other partners that aren't in the legislature, advocates, and so on. So I just want to share that with you, that's one of those efforts that we're making that I think is the right thing to do. I think it's public health, and I think that it protects the public. I think, in the midst of this overdose epidemic. So you might hear more about that over time. You may get questions about it locally, and I'll keep you posted. It's the sort of thing that, for me, it's the right thing to do, and if we're not successful this year, I can feel good that we've tried, that we've done our best to promote that. What I wouldn't feel good about is if there were an outbreak and we had just sort of, not really seized this opportunity to at least start the conversation and advocate for it on the part of getting this law passed. So I wanted to share that with you as much as anything to tell you that in the busyness and the worry about the budget and those sorts of things, we are continuing to do public health, as I know you're doing on a day-to-day basis out in the field. The other information I wanted to share, really, I think I've covered most of the stuff. I know that it's from the administrator's reports this morning. I know that it's a lot of stuff going on out in the field. We had a lot of good things shared. Some about the new buildings that are around the corner in a couple of the counties, some about the prostate screenings, the Wise Woman and Well Woman programs, and just little snapshots of the good and important work that you do on a day-to-day basis. And I want to tell you that I continue to appreciate that and appreciate each of you and the teams in the field. And we are here really as a team. I've said it before, the boat rises and falls together. I say that not only with the agency, but when you look look at some of the sister agencies and the important work that they do. We were delighted yesterday. There's another bill that is being introduced and it has some opposition, but it's to remove the exemption for faith-based child care providers from being licensed by the Department of Human Resources. Now, I will be the first to tell you that a lot of faith-based child care providers are doing an outstanding job, but that law that exempts them has such a wide loophole that basically almost anyone with a piece of letterhead could deem themselves as a faith-based organization and be exempt from the licensure by DHR. And that means there are no criminal background checks, there are no basic standards, minimum standards around student-to-pupil ratio, here the caretaker, the employee to the number of children, and all sorts of horror stories, if you will, that have unfolded over the past few years, whether it's a foodborne outbreak or harm to a child. A lot of advocates speaking yesterday in the committee hearing and sharing personal testimony, and frankly a lot of faith-based institutions, child care providers who were licensed and who were very much in favor of it because it's the right thing to do for children. So that's one that, while it's not squarely within public health's domain, it's still something that is for the health and safety of children, so we certainly support it wholeheartedly and hope that it continues to have success as it moves to the next steps through the legislative process. This was just that first initial committee hearing for that bill. So I'm going to ask, have we got any questions? We had solicited those in advance, that you submit those. So have we got any questions? Nope. Does anybody in the audience have any questions? Okay. Well, we've been going about, I guess, 25 minutes, so this will be a little bit shorter, but I'll close by saying I wish I could, hop around and visit every single county to do this in person instead of doing it remotely like this, but time does not permit that, and I just want to close by telling you how much I appreciate all you do, and please feel free to contact Central Office, me, or any of the other folks here if you have questions, if there's anything that we can do for you. And last thing I would close with is, Dr. Mary McIntyre, who's my chief medical officer. She actually lost her mom yesterday after an extended illness, so I would ask you to keep her in your thoughts and prayers. I know some of you have seen her recently because she's made several visits out in the field. I think she went to look at the dental clinic in Tuscaloosa, and she's been going to several areas around the home health program. So just keep Mary in your thoughts and prayers. So thank you.